In today's video, I'm going to be talking about pancreatic cancer. Most pancreatic tumours are adenocarcinomas, since the pancreas is of course a gland. They are most commonly found in the head of the pancreas, and so looking here at this diagram, this is the head that I'm circling. Less commonly, other pancreatic carcinomas can be ampullary tumours, or can be of the pancreatic islet cells, but these have a comparatively better prognosis than those in the head of the pancreas. There's a whole host of risk factors that can make you more likely to develop pancreatic cancer. So here we've got smoking, diabetes, older age, also chronic pancreatitis, high central adiposity, so a higher waist circumference is another risk factor, as is eating a diet full of lots of fatty foods, or one with lots of rare processed meat products. The incidence of pancreatic cancer is rising, and looking at a lot of these risk factors and how prevalent a lot of these things are in the Western world, like obesity and poor diet, we can begin to see why this is. There are various gene mutations that are linked to pancreatic cancer, but if there's one high-yield one that you commit to memory, it should be KRAS2, because this is mutated in around 95% of cases of the disease. Patients with a tumour in the head of the pancreas are likely to present to you with vague abdominal pain and weight loss. In tumours of the body and tail of the pancreas, this pain radiates to the back and is relieved by sitting forwards. There may be diabetes, acute pancreatitis, an enlarged liver, spleen and lymph nodes, and ascites. There are two particular features, though, which relate to tumours in the head of the pancreas, and I've intentionally left these until last. These are Courvoisier's sign and Trousseau's syndrome, and I'll talk about both of these in more detail next. Courvoisier's sign is the presence of an enlarged, non-tender gallbladder and painless jaundice. So let's break that down and think logically why this would happen. Looking again at the picture from earlier, you can see that at the head here is where bile drains into the duodenum, so the tumour will block the flow of bile, leading to jaundice. This is painless because the tumour grows slowly, and so the obstruction is gradual, rather than a sudden blockage and inflammation, as you'd find from something like a gallstone, for example. Other consequences of this obstruction in bile flow can include dark urine and clay-coloured and fatty stools. Now, let's take a look at Trousseau's syndrome. This is a simpler name for what we call migratory superficial thrombophlebitis. Now, that sounds quite long and confusing, so let's break it down and make it simple. Thrombophlebitis is inflammation and clotting in a vein. Superficial means that it is just below the skin's surface, and migratory means that it comes and goes in different locations. So, in migratory superficial thrombophlebitis, a patient will find that a vein in perhaps one leg, for example, becomes swollen and red, but then at a later date it goes away and appears on an arm instead, and so on. These inflammatory clots form in pancreatic cancer because the disease causes the patient to be in a hypercoagulable state. Imaging, usually CT or ultrasound, can be used to identify pancreatic tumour and can guide biopsies, but also help assess the extent of growth before surgery. We can do a blood test for a tumour marker called CA19-9. This is non-specific, but can be useful to monitor after treatment to assess prognosis. Most presenting cases of pancreatic cancer have already metastasised, and so prognosis is very poor, which I'll talk about in a minute. This also means that relatively few cases are suitable for surgery. When this is an option, though, the procedure that is done is called a pancreatoduodenectomy, otherwise known as the Whipple procedure. How this works is that everything in blue here is removed. The remainder of the pancreas is then hooked directly into a portion of the small intestine. Then the bile ducts and stomach are also both connected to the small intestine too. This means that the head of the pancreas is removed, and the tumour with it, but the bile can still drain and digestive enzymes can still be released into the digestive tract. This is a major procedure with high post-op morbidity. Tail tumours are comparatively easier to remove, and this can be done by laparoscopic excision. After surgery, post-op chemotherapy can delay disease progression. Also, a stent can be put in the bile duct to open up the obstruction and help reverse the jaundice. Pain, which can unfortunately become quite unbearable, can be palliatively eased with opiates and radiotherapy. As I mentioned earlier, pancreatic cancer has a very poor prognosis, and has in fact one of the worst of all cancers. The mean survival time is less than 6 months, and only 3% of patients survive beyond 5 years. With the Whipple procedure, 5-year survival does improve to around 10%. So that brings us to the end of today's video on pancreatic cancer. If you found this lesson useful, then subscribe for more summary videos,